name is Sam. I'm the 5th year student.
I'm Tan. Currently, I'm a 3rd-year student. My major is general practitioner. Yeah. So it's nice to meet you today.
Your guys' English is very good. Very good English. Yeah, I think so. So I'm going to teach you kind of some EKG, and EKG is important for all doctors to know how to read, and the best way to do EKG is have a system, and I'll show you my system, and I read EKG always in the same step-by-step fashion. That way you won't miss anything. So I'll show you kind of how I do my step-by-step fashion. I kind of learned over the last 4 years or so. And we'll show you some EKGs for syncope. Kind of not a very common presentation, but not many people present about what to look for. And if you don't know what to look for, you'll never find it. How do you, why is this not working? Oh, loading. And who's good at reading EKGs? Anybody here? We're gonna do some reading of EKGs. I'm gonna let you guys try first. If you get stuck, you can ask your professor. Oh, there it goes. Okay. So EKGs, syncope, especially in young patients. So for anybody with syncope, the kind of one of the number one diagnoses you have to worry about is pulmonary embolism. Do they know all English, or do they need to translate? No. Okay, so pulmonary embolism. Does anybody know what the most common EKG finding for pulmonary embolism?
S1,
S1Q3, T3. So that's the most specific finding, but not the most sensitive. So specific means that if you see that, there's a good likelihood that it is pulmonary embolism. But the most common common thing to find on EKG is tachycardia. Okay, so sinus tachycardia is the most common thing you'll see in pulmonary embolism. Most common pattern that you'll look for is a strain. Okay, right heart strain. There's a right ventricle is pushing against a larger afterload than it's used to. So when you look at the right heart, you look at the corresponding 2, 3, and ABF, which is your inferior leads. Inferior lead is right heart. Okay. AV, so this AVR and V1 are also right heart. Not AVF, AVR. So that's how you remember to look for right heart. And then the most specific finding in about 15% of pulmonary embolism is S1Q3T3. So if you only look for S1Q3T3, you're going to miss 85% of the pulmonary embolism. Anybody want to give this EKG a try? And if you can't figure it out, you can ask Dr. Ty, he'll know.
Parkinson White.
Full Parkinson White. Okay, this is pretty good. It's full Parkinson White. Do you want to go step by step? Rate. I go rate, rhythm, and axis. So rate. What do you think for rate?
60.
All right. So perfect. 300, 150, 100, 75, 60. Between 60 and 50, actually. Okay. Rhythm. Sinus. So you know, how do you know it's sinus rhythm?
P wave.
Upright P waves and 2, and down P waves and AVR. So perfect. Rate, rhythm, and then axis. So here's how I do it. Okay, so if you look at leads 1 and you look at leads AVF, right? So I draw it out. I draw it out every time, even now. Okay, so 1 is in this direction, AVF is in this direction. Okay. So is it up or down in lead 1? What do you think? Up or down? More down, right? So if lead 1 is in this direction, that means, and it's more negative, it's somewhere on this side. Okay? And then, oh. That's probably better. Then you look at AVF. So then you look at AVF. AVF is more positive, right? Yeah. So AVF is this direction. So that means that your axis is here. So your axis, where both of these two intersect, is where your axis will be. So a little, which deviation? Right axis deviation. Okay. So rate, rhythm, axis. Then I go PR interval. Do you know what the normal PR interval is?
Until 0 to 1 to 12.
12. Yeah. Good. 120 milliseconds to 200. This is one big box. Okay. So from here to here. So if it's longer than that, then you have a problem. If it's shorter than 120, which this one is almost non-existent, then you have to worry about, if it's shorter, you have to worry about Wolff Parkinson White. If it's bigger than 120, you have to worry about block. Yeah, AV block. So this one is shorter. So I still look at the rest of it. QRS is wide, right?
Yeah.
QRS is, and what's normal QRS? 120, less than 120 milliseconds, which is 3 little boxes. Okay? And then QT, you know how to figure out QT?
until 450.
Yeah, so I make it easy, 500 for men. They have different numbers for men and women, but I don't normally worry about it until after 500. But the easy way to look at it is you look at here's R, here's R. Okay? From Q to T. If this QT is greater than 1/2 the R to R, then you're worried about long QT, okay? So if this came out to here, and you were looking, this is your QT, it's greater than 1/2 of that R to R, then you would be worried about a long QT. And then the last thing that I look at is ST depression and T wave inversion. I look at it together, and I look at it in the leads with distribution for the blood. Yeah. So V1 through V6, you know, you think LAD. Okay, so you look at all these together. You look at 1 and ABL together, and then you look at inferior leads all together. Okay. So this one has T wave inversion, T wave inversion, T wave inversion, T wave inversion. Over there, ST, T wave is okay. T wave inversion in AVR is normal. T wave inversion in AVR and V1 is normal. Okay. 2, 3, and AVF, they all look okay. So it's like what you were talking about, Wolf Parkinson White. We had a very short PR interval, and then we had a long QRS. Okay. And that's pretty much it. The problem is you can have atrial fibrillation or atrial flutter that can cause you, if you go into this rhythm, you're gonna not have enough filling time in your heart, and you'll pass out. We actually had this case.
Yeah.
When first day I came here.
She's still alive.
She's still alive. Yeah, thankfully Dr. Tai was taking care of her, and she's still alive.
I have a question then.
Yeah.
If the patient have the left atrial enlargement,
Atrial enlargement, yeah.
This may increase the time of the P wave. This means that, for example, in this situation, if the have the left atrial enlargement included with Parkinson White,
Yeah.
the PR interval can be longer than 0.2.
Oh.
You see that?
Yeah, because if it was like atrial enlargement normally looks like this in any lead. I don't know how to answer that. But the reason that you have the delta wave here, you have the heart here. Okay, you have SA node going to AB node. Okay. Normally, you have your impulse coming here and then going up here, right? But the AB node is slows down impulses, okay? So you have P, Q, R, S, and you have this break right here, which is your AB node. It slows it down, okay? And the reason it slows it down is once you have impulse from here to here, it takes time for the heart to squeeze blood down to here. So then you have that time, and then you can have your QRS and squeeze it to the rest of the body. So that's what you need this time right here. With Wolf Parkinson White, you have an accessory pathway, bundle of Kent, and you have a signal, but the signal goes directly through. Okay, you don't have this block at the AB node. So you'll have your QRS, and you'll see this instead. And that's why you have a delta wave, and you have the short PR interval there. Okay? We could do more about Wolf Parkinson White, but I think it's too much. That's a whole lecture by itself. So, in the emergent cardioversion, emergent treatment is cardioversion. Semi-emergently, then you can give the medication. And long term, they need that bundle of Kent ablated, burn. They burn out that bundle of Kent. So, do you know what the when we say emergent cardioversion, what is the indication? Why would it be emergent versus semi-emergent?
Because we have
Like say that patient is sitting in front of you and you have to make the decision, am I going to shock this person, right? Kind of a big decision. What says I have to shock this person? What about the patient or vital signs tells you you need to act right away?
hypotension.
Absolutely, hypotension. So there's 4 things: chest pain, shortness of breath, hypotension, or confusion. Then you need to cardiover. And this is not just Wolff-Parkinson-White, this is VTAC, VFib you always shock, AFib, any of these tachycardias where you have chest pain, shortness of breath, hypotension, or confusion, you need to shock them right away, or they can go into VFib arrest. Alright, and these are kind of just special EKGs that you will never, you won't catch it unless you know what you're looking for. So, anybody have a guess as to what this one is? Yeah, yeah, definitely. It's Brugada syndrome. Good. And can you tell us what how you know it's Brugada, or what you see?
Yeah, I see the V1 and V2 that have an image of the picture like in the ST and the ST in V1 V2 with elevate.
Yeah, absolutely. So you have really large ST elevations in V1 and V2, and large T-wave inversion, ST T-wave inversion. So that's Brugada pattern. So for Brugada pattern, could be a young person, they have syncopal episode. Anybody with any young person with a syncopal episode, you need to look in V1 to look for Brugada, okay? So Brugada, coved ST segment elevation, followed by a negative T wave. And this is just something you have to memorize. There's nothing you can really, no way of like memorize it. You just have to remember to look for that in somebody who has a syncopal episode. What do you guys think? This is another special case. This is called arrhythmogenic right ventricular dysplasia. Okay?
Yeah,
And
negative in V2, 3.
yeah, you have T-wave inversions in the V1 through V3, and you see here you have this little notch. Okay, little notch here. Okay. So for all of these kind of special things you look for syncope and EKG, look at V1. V1 is the special lead you need to look for syncope EKG, especially in young patients. So you have the epsilon wave, which is that little wave right here. You can see it here as well. You can see it in all of these these leads here too. But it's supposed to be specifically V1, you should see it. Epsilon wave. T-wave inversions in V1 through V3, like Dr. Hien said. And what about this one? Oh, also, do you know what other EKG gives you notches here? You'll never see it in Vietnam.
Hypothermia,
Yeah, hypothermia.
G-wave,
J-wave. Osborne J-wave, yeah. That's one. There's another one too that gives you a notch right after the QRS. benign early repol.
Benign
Benign early repolarization with ST segment elevation. So sometimes ST segment elevation, you're worried about heart attack. But in a young patient, not that likely. And they have ST elevation sometimes, but they also have a notch here, and that's kind of a way you know, oh, it's probably not ST elevation MI, myocardial infarction, but probably just benign early repolarization. What do you guys think about this one? Okay, not in this presentation. Something's wrong.
3D,
Long QT. So if you have R on T phenomena, so the R wave falls on your T wave because the T wave is so far away, then you can have this. Do you know what this is? Anybody? Torsades, yeah. So what's the treatment?
Magnesium.
Hip shock with magnesium. 2 grams of magnesium. Okay? So long QT. So like we said, the rule of thumb is less than half the R to R. If they're on any of these medications, you need to stop it. Some electrolytes can cause long QT. You need to replace those electrolytes and definitely check for magnesium. Magnesium doesn't come in our normal metabolic panel. I don't know about here if it comes with, does it come in your normal orders? Can you order magnesium level?
I'm not sure.
You can. So you're gonna need to order magnesium level. Anybody who comes into the emergency department or in general and they come in with a cardiac problem, you should check magnesium. Anytime you want to replace potassium, you have to replace magnesium with potassium, otherwise the potassium won't be absorbed. So treatment, magnesium, and stop the offending agent. How will this go? Young, healthy guy comes in, was playing football, went to go kick the game-winning goal, fell over. So if you look at this EKG, does anything about the EKG look weird? Just looking at it, not really too close, just kind of looking at it very superficially. So Q waves are pretty much never normal, okay? But we have large Q waves in V5, V6, very narrow, very large Q waves, which is very abnormal, okay? That's hypertrophic cardiomyopathy. They are called dagger Q waves, and you have unexplained syncope. This can cause you to go into VFib arrest when your heart rate goes too high. And it will block the outflow, the aortic outflow tract will be blocked by the septum, and they'll pass out. So long term, they can ablate, burn up some of the septum, or they will place the patient on beta blocker, because the faster your heart rate, the more likely you will have your aortic outflow tract obstructed. So ablation of tissues, that's pretty much it. So review, you want to look young person, you want to look for pulmonary embolism. You want to look for Wolff Parkinson White. You want to look for Brugada V1. You want to look for ARVD and V1. And you want to look for long QT and hypertrophic cardiomyopathy.
In the case of hypertrophic cardio, in this case, do we need an echo?
Yes,
We need an echo.
they need an echo, and they need possibly a defibrillator replaced. Defibrillator.
Yeah.
You can't really, I mean, you could be suspicious of this, but without an echo, you can't really tell.
Yeah.
So they should be admitted for echo and for possible, defibrillator